Yes, good morning, everyone. We are from Ovia Health. I will do some quick introductions and then we will get straight into it, chatting about menopause and how Ovia can serve you today. So I am Ovia Health's account manager. We're joined today by Elaine Bishop. She is a certified nurse midwife who has been working in maternal child healthcare for over 15 years. She began her career as a labor and delivery nurse in a high acuity inner city teaching hospital and then transitioned to low risk hospital setting as a labor, delivery, postpartum, and newborn nursery nurse. For the next several years, she worked as a full scope certified nurse midwife and enjoyed attending births throughout their lifespan in the office setting. Most recently, she worked in a fetal care center and used her expertise to develop a maternal cardiac clinic and a cancer in pregnancy clinic. Elaine holds a bachelor's degree in biology and a minor in chemistry from the College of Worcester. She also received a post-baccalaureate certificate in nursing from Case Western Reserve University, and she holds a master's in nursing from Vanderbilt University in nurse midwifery and is a Menopause Society certified practitioner. Whew, that's a mouthful, Elaine. Thank you so much for joining us today and bringing all of your expertise to share with MESSA and MESSA members as we chat about menopause.
Absolutely. Thanks so much. I'm super excited to be here with you all this morning. And I think that we have some really good info to share with you all. Like Tracy said, I'm a Menopause Society certified practitioner. And that means that I have spent a little extra time focusing on the current evidence in menopause care, the standard of care that people should being offered during menopause and perimenopause. And I want to bring some of that knowledge to you because it is unfortunately a well-kept secret, and we're trying to change that. So, today we're going to talk about what is menopause, what's happening to your body during it, what can you expect, how do we live with the symptoms that pop up, and how do we manage them to be our best, happiest, most healthy selves, and how can Avia support you through that transition? Um, so why spend time talking about menopause? What's the big deal, right? Well, half of the population goes through it. Actually, there's like slightly more women in the world than men, so more than half the population goes through it. And it's coming for all of us, ladies. So like, there's no avoiding it. And the thing is, historically, the common approach was, this is a natural occurrence. You're fine. Just get through it. You're going to be all right. And so that's kind of how women have fallen into line about um, managing their symptoms. And so, even though over 75% of women will experience vasomotor symptoms, which are those classic hot flashes and night sweats, um, they don't bring it to the attention of their provider. They don't talk about it. They don't ask for more support and help with their symptoms. Um, Only about 50% of women ever bring up some of their symptoms to their providers. And that is, I think, a generous statistic, actually. And this impacts our home lives, it impacts our work lives. Research has been being done about how menopause affects your attendance in the workplace. And actually, women are missing work, they are leaving the workforce altogether. And so that doesn't have to happen. We can manage this and we can get through this um, and stay at the top of our game, right? Because menopause hits us a lot of times when we're like in the peak of our career. We've developed expertise in our areas of study and our work, and we're excited to like share our wisdom and our experience. And so to be leaving the workforce at this time of our lives, it can be a real huge disappointment. So we don't have to go there. So let's talk about what the heck is menopause anyways. And so menopause is all about our ovarian function. And our ovaries change a lot through our lifespans. So when we're born with all the eggs we're ever going to have, and it just decreases from there. Our fertile years are after you've started having periods, so in puberty, and then it goes through menopause when fertility ends. And perimenopause is that time between when we're fertile and having regular cycles and ovulating regularly. It's the time when our ovaries are starting to become less responsive to the menstrual hormones. And they are starting to not ovulate as regularly and not respond to the hormonal signals in our bodies as much. And so, what our bodies do is they create more hormones. And they're like, okay, if you're not going to respond, I'm going to make a whole ton of follicle stimulating hormone. And I'm going to say, come on, ovaries, make that estrogen, grow that follicle, make sure that it's maturing. And then the ovary is like, can't hear you in the back. Gotta speak up. So your body's like, cool, I'll push more hormones out. So you're riding this wave of hormone when you're used to riding waves, but these are like the biggest roller coasters, right? And maybe your ovary says, okay, let's ovulate this month. And so the follicle releases, you get progesterone going, that drops, and you have a period. But maybe it doesn't. And maybe your body continues to push out hormones and you continue to feel wonky. That is perimenopause. So that's why perimenopause is a time when symptoms show up so much because all of a sudden your hormones are at different levels than they've been in your life and they're changing regularly. They're not in a typical cycle that you're used to. And it causes cycle irregularity. So that's why your periods show up sooner than you'd expect, later than you'd expect. They can be heavier than usual, they can be lighter than usual. It's a little bit like puberty again. It's like you're in gym class and you need someone to wrap a sweatshirt around your pants because you bled through them. Like nobody wants that, right? But it happens, and that's part of the process. And so we're going to talk about how to, stay in tune with our bodies and try to anticipate some of those events as they happen. But so perimenopause can last up to a decade. It can be a couple years for some people. Typically starts around our very late 30s, early 40s for some. Some start mid 40s. Some will start much earlier. And then menopause is just one moment in time. It is when you have officially gone 12 full months without a period. And so perimenopause can be broken up into two stages, early and late. Early perimenopause, your cycles vary by about 7 days or more each cycle. Late perimenopause, you're going to go 60, 90 days without a cycle. You'll go 6 months without a cycle. And for some people, they'll continue and go that 12 months and be menopausal. For others, they'll have a period at the 6 month mark and the clock starts over again. So once you have not had a period for 12 full months, then you are postmenopausal. And that is when your ovaries are no longer functional. They are not producing estrogen anymore. And that is the rest of your life. So we can spend almost half of our lives in menopause if we live long enough, right? And that's the goal. So, um, let's talk about when to expect this transition. Um, it varies widely. The average age in the United States is 52. Um, it most commonly happens between 48 and 58 years old. But there are a lot of things that can affect when you individually go into menopause. It's often very close to when your biological mother did. And it is also dependent upon medical conditions, genetic conditions, lifestyle, physical changes. So there's a lot of contributors. And um, we can go to the next slide, Tracy. You can go into premature menopause, and this is commonly if you have a genetic condition that causes the ovaries to shut down earlier than expected. So, primary ovarian insufficiency is a condition where you don't have eggs and you don't have as many eggs, and your ovaries don't work as long in your life, and that can be genetic or it can be random. Um, and that can be a really devastating condition in terms of, infertility, and it changes your life to go in through menopause when you're very young. So it's something, if you're going through that, it's something worth getting medical attention for, not just from the standpoint of understanding your fertility, but also understanding how menopause affects the body in the long term and what treatments are available if you're having premature menopause. Early menopause happens when you're between 40 and 45. There are certain lifestyle behaviors that can affect that, like smoking, can cause early menopause. Surgical menopause is when you have to have your ovaries removed, and that's a very abrupt way to enter menopause, and it can come with some pretty intense symptoms because it's so sudden. Um, so let's talk about what the symptoms are that you might be experiencing. And I'm seeing a couple of questions come up. Let's see here.
I was just about to say that. The first one, the criteria about going 1 year without a period, how was that determined? Do you have any insight on that? I certainly don't. It's a bit of a, well, we need some sort of criteria, so maybe like a year or based on what we know so far. So just any insight you might have there.
Yeah, absolutely. That's a great question. So, um, I'm glad you called that out because it is possible to suddenly have a period after menopause, after that 1 year mark. The vast, vast majority of people who go 12 months without any vaginal bleeding have no ovarian function anymore. Um, Occasionally, someone will have a period after that menopausal point. And I actually have postmenopausal bleeding in bright pink here in the next slide because that's a red flag symptom. Anytime you have bleeding after the 12 months of not bleeding, you need to have that checked out. Occasionally, it can be normal. And you could be one of those people who have a period after the 12 months and you had a little bit of ovarian function left and then it's no more. But postmenopausal bleeding is always a warning sign because it can indicate uterine cancer. The endometrial lining, or the inner lining of the uterus where a pregnancy would implant, grows during your menstrual cycle and then is shed when you have a period. Endometrial cancer happens when that lining grows and grows and grows unchecked. And it can cause spotting, it can cause heavy bleeding. And so, anytime you have bleeding after you are expecting to no longer have bleeding, you always have to get that checked out to make sure that it's not endometrial cancer. But yes, basically, the 12 months is like an average. It's more than average, though. It's the vast majority of people have no more ovarian function at that point. Okay, so let's talk about symptoms. Irregular periods are often the first thing people notice, and this can begin at the end of your fertile years and the beginning of your perimenopausal time, where you'll notice like subtle changes, like, oh, that was a weird period. That was a little heavier than I'm used to, or that was a little lighter than I'm used to. And it ranges all the way to um, I haven't had a period in 45 days. I know I'm not pregnant. What is going on here? That's really, really common. Hot flashes start to show up, and that is directly related to hormone fluctuation and low estrogen. Insomnia and sleep disturbances are incredibly common. Vaginal atrophy, we'll talk a little bit more about that later on, but that is part of the constellation of symptoms called genitourinary syndrome of menopause. And it's basically the vulva, your external genitalia, the vagina, your internal genitalia, and your urethra and your urinary system, so where you urinate from, those are all very dependent upon estrogen. And estrogen keeps those tissues elastic and moist and supple. And without it, they atrophy. They become less stretchy, they become drier. And that can cause a lot of itching, irritation. It changes the pH of the vaginal area, and so you can get infections and irritations that you haven't had before. You can get frequent urinary tract infections. So these things are life altering. They're not mild push through it kinds of symptoms, right? These are things that we need to get attention for and treatment for. Um, Other symptoms. So we have estrogen receptors in almost every area of our body, our joints, our brains. So memory concerns start to show up. You hear about brain fog, mood changes. Estrogen's responsible for helping maintain serotonin levels in the brain. So it can affect that. Um, Decreased libido is another common symptom. Weight gain is very, very common, and decreased fertility. And a note about that. Perimenopause is a time of decreased fertility, not absent fertility. So this is also a time when unexpected pregnancies can show up. So have that in your awareness that until you have gone 12 months without a period, you are still potentially fertile and could conceive because you're still releasing eggs.
Elaine, quick question came through the chat. Is there medical evidence supporting the efficacy of the use of peptides to support hormone therapy? There seem to be many hormone treatment facilities with integrative medicine and functional health facilities. Just wondering about your thoughts on that.
I am not familiar with that. I will look into that more to learn more about that, but I am not aware of the Menopause Society promoting that as a treatment for hormone balance, health, whatever. So good question. I'm sorry, I don't have the answer.
We can get back to you on it though.
Yeah, absolutely. Okay, so let's talk about how do we manage symptoms. There's a whole lot of different approaches, and I just chose a couple different common symptoms here to talk about how they're approached um, when you're either using medication, prescription medications, or therapies, or whatever. So, insomnia and sleep disturbance is really common. So, what do we have to do? We have to figure out, why am I experiencing this? Is it environmental? Do I have a TV on in the room all the time? Do I use a screen before bed? Do I have a lot of noise in my neighborhood? Um, so identifying whatever environmental stimuli you can adjust. Following a regular sleep schedule is always advised. Avoiding naps actually helps increase your sleep drive at night. So even though you're tired during the day, avoiding a nap, like so adjusting your lifestyle to maximize your ability to sleep at night. Um, a cooler bedroom temperature is helpful. Exercising earlier in the day versus later in the day, avoiding caffeine and alcohol. A lot of people think like, okay, I'm having trouble sleeping, so maybe I have a couple drinks before bed and that will help. And that might help you fall asleep faster, but you will have less restful sleep. And the second half of the night is actually more interrupted sleep when you have alcohol in your system than when you don't. So avoiding alcohol and identifying if you're having a mood disturbance, if you're having anxiety, if you're having depression, treating those things with medication, with talk therapy, with other interventions that are helpful to you. Um, and then using a therapy like CBTI. CBTI is a type of cognitive behavioral therapy specifically for insomnia, and it has shown a lot of success for people who have menopausal sleep disturbances. So, so basically, when you're addressing any symptom in menopause, you want to go through and find, what in my life can I adjust? What do I need help adjusting from my healthcare provider? What medications or therapies might be appropriate to help me overcome this barrier going on in my life? Another example of a symptom, the genitourinary syndrome of menopause, GSM. And you can approach it in several different ways, but typically this is treated with um, either over-the-counter products or prescription therapies. So initially you want to look at, am I wearing cotton underwear? Is it dye-free, scent-free detergent? Things that you can, shift, wearing loose pants, not leggings all the time. Those things can help in your day-to-day comfort, but truly they're not going to cure GSM because it's a hormonal thing. So using a vaginal moisturizer. This is different from a lubricant in that it is a bioadhesive product. So that means it like sticks to the cells and it provides more moisture than an in-the-moment lubricant. Certainly using lubricants when you're engaging in sexual activity is very helpful. But the vaginal moisturizer is used a couple times a week and it increases general moisture in that area. The next step is using low dose localized vaginal estrogen cream or a DHEA suppository. DHEA is a hormone, it's a precursor to estrogen, and the cells in the vagina transform it into estrogen when it gets in there. So those are both really, really safe options for people. They are prescription, so you have to talk to your provider. Um, and they're not safe for every single person, but they are safe for the vast majority of women and can be used for the rest of your life and is like game changing when you're suffering with GSM. So those are just a couple examples of kind of how treatment is approached. And I want to talk a little more in depth about prescription therapy options.
Before
So
we jump there, we have one question. Are there any differences with hormone or body effects with an early hysterectomy that left the ovaries?
great question. Yes. We don't really understand why, but having a hysterectomy, even when you leave your ovaries intact, can bring on earlier symptoms of perimenopause. A lot of people who have this experience more intense hot flashes, and we don't know why. So I know you also said that hot flashes are the worst. They are. They're really, really bothersome. Um, so I'm sorry if you're dealing with that. But there is truth to that, that having a hysterectomy, even if you keep your ovaries, can give you symptoms of perimenopause early. So what can you do about that, huh? Let's talk about it. So there are a lot of options. Hormone therapy gets thrown around a lot, and that is one treatment option for specific symptoms. Hormone therapy applies to hot flashes, night sweats, genitourinary syndrome of menopause, and it can be preventative of osteoporosis, which is brittle bones, lower bone density. So, it's not prescribed for all symptoms of menopause, but it is very, very effective and helpful, for those who can take it. Estrogen therapy is used alone when you have had a hysterectomy, and you have to use a combined estrogen progesterone therapy when you still have a uterus because of that endometrial lining that we talked about earlier, that if it grows unchecked, it can become endometrial cancer. And estrogen encourages the growth of that endometrium. So if we have a uterus to grow that tissue in and we're giving you estrogen, it's going to grow, grow, grow. Progesterone keeps it at bay, keeps it from overdeveloping and becoming a cancer. Um, Another hormone that's used very specifically during perimenopause and menopause is testosterone. It is prescribed for people experiencing low libido that is bothersome to them. Um, and then there are a lot of non-hormone based prescription treatment options. SSRIs and SNRIs are typically prescribed for mood disorders. And usually, when you're prescribed one of these for a mood disorder, you'll be told it takes 6 to 8 weeks for this to kick in. So it's kind of a long time to see if it's going to work for you. But actually, they have found that at much, much, much lower doses than used for mood disorders, these work for hot flashes. And bonus, they work pretty quick. Like within a week, you'll know if it's working for you to treat your hot flash. So that's kind of cool. That's a different option from hormones. Veoza or fezolinetant is a medication, one of the first that has been developed specifically for us. It is meant to treat hot flashes. It works in the temperature regulating area of the brain, and it helps keep your body from signaling like, we need to cool down, push all that blood to the surface and give you a hot flash. So that's kind of cool. And it works pretty well and it has very minimal side effects. Another option is a medication called gabapentin. We don't really know why this works for hot flashes, but it does. Um, it does have some gnarly side effects, so it's not very well tolerated by everyone. It can make you feel pretty sedated. So those are just some examples. There are more out there, but I didn't want to go through every detail. It's a little bit overwhelming. But just so that you know, if you try a medication and it doesn't work for you, you're not out of options. Keep going, keep trying to find what's going to work for you. There are some cautions to be aware of around these prescription therapies, as there are around any prescription therapy. So, a lot of fear developed around hormone therapy back in the early 2000s because the Women's Health Initiative was a really big study, a really helpful, valuable study. But the initial interpretation of the results suggested that hormone therapy is very dangerous in terms of increasing breast cancer risk, increasing cardiovascular disease risk, increasing dementia risk. And overnight, estrogen prescriptions went to nil. People flushed it down the toilet, they stopped using it, and they stopped studying it. And a generation of women went through menopause without hormone therapy as an option. And that was such a huge disservice to people. Further analysis of that data and follow up on the patients who were in that trial has found that really, when used appropriately, meaning in the right age group, hormone therapy is massively beneficial, massively. And it's not safe for everybody. And the more research we do, the more we can dial in who is going to be really, who's going to get great benefit from it and who should avoid it. So, that study showed that when you're over the age of 60, you're more than 10 years out from your last menstrual period. Starting hormone therapy might pose more risks to you than benefits. And so it might not be the best choice. Under the age of 60 and within 10 years of your last menstrual period, there are benefits, like I mentioned, treating hot flashes, night sweats, and preventing osteoporosis from developing. If you have a history of blood clots, heart disease pre-existing, having had a stroke, gallbladder or liver disease, then hormone therapy might not be an option for you. Same with if you've ever had an estrogen sensitive cancer. Probably not going to be the best choice. Then you'll lean on the other medications that are options for you. Ultimately, it's always good to talk with your doctor to know your specific risk factors. Um, and the more we learn, the more it seems to open up this as an option when used appropriately for people. So, um, it's starting to look like there are some cancer patients who've been denied hormone therapy in the past who might actually be safe candidates. So it's always worth approaching your oncologist, your primary care physician, your women's health provider, whoever you trust and knows your health history. They're going to help you figure out what the best medication treatment options are for you. Um, some of the side effects and cautions around the non-hormone medication options, SSRIs and SNRIs can initially cause a little bit of nausea, dizziness, sleepiness. Those typically fade with time over use, but often they can be taken at night to avoid experiencing some of those side effects. Um, Veoza can cause liver toxicity in a few cases. And so when you are starting that medication, you do need to have your blood drawn every few months to monitor your liver function. And if it's okay after that, then you don't have to continue having blood draws typically. But it's something to be aware of that your provider should order some monitoring to make sure that your liver isn't being negatively affected. Gabapentin, I mentioned, can cause really some sedation, dizziness, makes you feel real sleepy. So sometimes people will start it at a very low dose and gradually move up so that you can kind of get used to it and tolerate it. And it's often taken at night. And it can be a great option for people who are particularly bothered by night sweats and sleep disturbance because it treats night sweats and it makes you sleepy. So you get kind of a double whammy with that one. So, um, okay, I see a clarification. To clarify, women over 60 should be cautious about starting hormone therapy. That's yes, that is the prevailing wisdom right now, that if you are over 60 and you have not yet been on hormone therapy, then it is something to discuss with your provider very intentionally to determine if you're a good candidate. It doesn't mean that no one over the age of 60 should ever use hormone therapy, but it's most ideal started under the age of 60. And those people can then continue taking it until they and their provider decide together that it's time to stop. But it's encouraged to be started before the age of 60. Yeah, I can't answer that specifically for you about the fatty liver question. That is something that you'd have to really work with your provider on and just decide, every therapy, every medical intervention, surgery, medicine, whatever, has risks and benefits. And it's always uh, ideal to bring that to your provider and say, I want to have an intentional discussion with you about what are my risks and what are my benefits, because they're different for everybody, and then determine which one outweighs the other. And that's called shared decision making. And your provider should be offering you shared decision making all the time. So they should be educating you on the risks and benefits, educating you on your options and alternatives, and helping you decide what's going to work for me in my individual situation. It's so hard to wait for appointments. I'm sorry. It's I just want to validate that. That's so tough. Yeah. So I've talked a lot about medicines and prescriptions, and so what can we be doing outside of medication to treat these things? And there are non-medication options that are great. The Menopause Society released, I think it was like almost a year ago now, maybe, that a study was done to look at. We already knew that clinical hypnosis and cognitive behavioral therapy were both helpful for hot flashes, but they did another study to like really assess how effective they are. And actually, clinical hypnosis came out on top in terms of treating hot flashes. So people can go to someone certified in clinical hypnosis and they get taught how to do it for themselves. And then you can do it at home whenever you're experiencing a hot flash or a night sweat or other bothersome symptoms. And so both of those are effective and are strongly encouraged to explore if you're not wanting to use pharmaceuticals. There are a lot of questions out there about supplements and herbal remedies. And unfortunately, we just don't have great data on these things. There haven't been a lot of studies, and the studies that have been done have really shown us that some people have a benefit, some people have no benefit, some people have side effects and medical interactions with other medications they're taking. And um, so there isn't overwhelming evidence that any one of these supplements or herbal remedies really helps. Um, but it doesn't mean that they don't. It just doesn't, it just means that it's not like generalizable to the whole population that like most people get a benefit from this. So you want to work with your own provider to determine, hey, would trying out this remedy maybe be an option for me? Is it safe? And then if you try it and it works, then by all means, keep going. If you try it and it doesn't work, then maybe move on to the next option. I've talked a little bit about osteoporosis, but I wanted to touch on the fact that these years of our lives are a time when other conditions are very common and increasing. And so cardiovascular disease, cancers, and osteoporosis all become much more common in this time period. And these can be directly associated with our estrogen levels. Women without ovaries, like people who had their ovaries removed early, develop heart disease at the same rate as men. Women prior to menopause have way less heart disease than men. But once we hit menopause, we very quickly catch up to men in terms of our heart risk. And heart disease is still the number one killer of women. So we are not, an exception to that. There are risk factors throughout your life that contribute to your risk of heart disease, in addition to the fact that you are going through menopause and having lower estrogen levels. So, if you have a lot of vasomotor symptoms like hot flashes and night sweats, you have an increased risk of heart disease. We've made that association. We have not figured out how to mitigate that association. So even if you treat your hot flashes, your risk for cardiovascular disease remains higher than someone who doesn't have a lot of hot flashes. I wish we knew more. We're hopefully learning more with research, but it's something to be aware of and share with your provider. Same with things like before I learned this, I wouldn't think to tell like my PCP in my 40s and 50s that I had preeclampsia with a pregnancy. But they need to know that because having preeclampsia in a pregnancy increases your later life risk of cardiovascular disease. Crazy, right? So it's important to bring your history with you and share with your current healthcare provider what you have been through in the past because it's relevant. Managing Um, having a larger waist circumference is associated with increased cardiovascular disease, smoking, high cholesterol, high blood pressure. Those are all things that we need to adjust our lifestyle for, um, to be managing and making sure we're as healthy as we can be to reduce our risk. Cancer screenings are so, so important. Alcohol use is really normalized in our culture, but it is a carcinogen. And so keeping that in mind and moderating our intake is very important. It is directly related to breast cancer risk, alcohol intake. And so a moderate amount for a woman, I believe, is two or more drinks a day. It's kind of a lot. But it's easy to do if you're not paying close attention. And so keeping that in mind that increases your risk. So cutting back as much as you can. Plant-based diets have been shown to be preventative against cancer. Something in the American diet, we do not get enough fiber. We don't get enough fiber. So um, I thought they just reduced it to one drink a day or less for women. They did, yeah, it is recommended that you are one drink a day or less. I was just speaking to moderate intake, which is not considered safe, which I believe is considered two drinks a day or more. But the safe level is actually no alcohol. Um, if you're going to drink, it is advised that you have one drink a day, but ideally less than that. Um, yeah, so we need to increase our fiber intake. And a note on soy. It used to be talked about that soy was like risky for developing breast cancer, but actually a study has shown that those who consume soy products in their diet regularly prior to a breast cancer diagnosis have decreased mortality from breast cancer. So it is actually encouraged that you consume soy products. Osteoporosis, brittle bones. Um, this is a really, really, really common issue. And our bone health peaks when we're in our 20s. So if you are in perimenopause, you are already on the downtrend big time. And once you are postmenopausal, estrogen, that decrease in estrogen really tanks your bone density. And so working with your provider to make sure that you are optimizing that and aware of your family history. That's really important. Talking about the emotional side of this has been a lot. We've talked about a lot of unpleasant symptoms, a lot of change, um, and it is a time of transition, and humans are generally resistant to transition. We just are. It's hard. Um, but it doesn't have to be all bad. It is important to identify the difference between grieving this transition and developing depression. Depression is a condition, it's hormonally mediated, it can be treated. Grief is a natural process that we work through, but both require support, and you are worthy of getting the support that you need through this time of shifting and changing. And I just want you all to know that you are worthy of being heard, um, and your emotional state is valid and treatment is available. So if you are feeling depressed, if you are feeling anxious, if you are struggling with the shifting and changing of your body, then reach out for help. Ask your provider for help. Some things that you can do at home, um, Tracy, you can go to the next slide, are finding ways that you cope with change, ways that you can care for yourself, um, and ways that you can support your own mental well-being. And actually, let's go to the next slide, because in the app, you'll find that we have a daily self-care checklist. And these are just suggestions to jog your thinking through. How can I care for myself? What can I be doing to feel my best? Um, and these are some suggestions for um, things that you can address. And some of them are more time consuming than others. But developing a habit of doing a self-care practice on a daily basis accumulates positivity, and it helps shift your mindset, and it helps you take care of your body, which helps take care of your mind and your heart. There are happy pieces to going through this transition. You don't have a period anymore. Whoop, whoop. You don't have PMS anymore if you have been dealing with that. If you have hormonal headaches, say goodbye to those. You can have sex without the worry of having a pregnancy once you're postmenopausal. Um, Uterine fibroids shrink. If you have endometriosis, that decreases because you don't have the hormonal fluctuations anymore. There's a lot to look forward to. And we are some of the only mammals who survive beyond our reproductive years. And it's really an interesting idea that we are no longer biologically reproducing. We're not like contributing in that sense anymore, but we're worth sticking around because we're so valuable. Our presence here, like something new that we had to stick around after we're done making babies, because people need us, our families need us, the world needs us. So that's why we're still here. And so we need to make the most of it and be the best selves that we can be, right? um, to be the best self you can be, unfortunately, right now, it does rest on your shoulders to advocate for yourself. I wish it didn't. I wish that everyone was just going to like step in and take care of you right away. But research shows that women visit 4 or 5 different providers before getting attention for their menopause symptoms. So keep keep looking for a provider. They are out there. There are people who really want to treat you for these things and want to address your symptoms. If you need help finding a provider, the Menopause Society has a directory of the Society certified practitioners. If you go to menopause.org, you'll be able to find their directory. And don't be afraid to bring someone with you to your appointments who's going to help you advocate for yourself and help you speak up. I want to spend a couple minutes on our app and our solution and how Ovia can support you. So, we have a ton of content in the app. We have the ability for symptom tracking, and we have one-on-one support through our care team. And we really, really want to be here to support you all. So we want you to engage as much as you find helpful within the app. Um, there's educational support. So we have 60 plus in-app articles. We have a series of going through like, is this menopause? Is this perimenopause? What's happening? What are the symptoms? How do I manage my mental health? Why tracking symptoms is helpful or valuable to you. Um, we have data feedback. So when you track symptoms, you'll get notifications like, hey, you reported a symptom that seems really um sorry, I got distracted by the chat. This is part of perimenopause. My brain is all over the place.
There are a couple
Um,
questions we can pop back to,
yeah.
Elaine. You're totally
Okay.
right.
Okay. Um, yeah, so you'll get notifications in the app like, hey, you logged a red flag symptom. You should call your provider and check in with them. Um, and there's data feedback like, hey, you've been logging this for a while now. Are you experiencing something bothersome? Do we need to help you address this? There's helpful tips and tricks in there. And then chat with me and my friends. Ovia's has a care team. And so we have health coaches, we have care advocates, and we are all here to support you. You can write into the app 365 days a year, 9 a.m. to 9 p.m. You can write in after that, but we'll answer you the following morning if you write in at night. And we want to be here to support you. And we're not just menopause focused, so you can check in with us if you're trying to conceive or pregnant or parenting, or asking about general women's health topics. We are here for you. We're not bots. And then I put in here some general menopause resources that might be helpful to you all. You'll have access, I think, to the slides
Yes.
after this, right? Yeah.
Yes.
So you can lean on some of these resources because they are very helpful. Um, and then Tracy, I'll turn it back over to you.
Yes, absolutely. So we did have one or two questions. I'm going to scroll back up. I know one was regarding a mammogram. Jackie was interested in an ultrasound instead. How would you go about asking for something like that?
Oh, you can talk to your provider, discuss with them. Why are bring to them what's the benefit of a mammogram? What's the benefit of an ultrasound? Why would I choose one over the other? Why would any provider choose one over the other? Have that discussion about your risks and your benefits. Is an ultrasound going to show them the same thing that a mammogram is? Um, those are some good questions to start with and just
Great.
have an intentional discussion.
I know, Rhonda, you're going to keep us on track for timing, but we do have one or two more questions that have popped in. Thyroid issue symptoms seem to be very similar to perimenopause. Suggestions on how to explore the difference or connection with a doctor for proper treatment.
That's a great question. And I will note that often people want to have their labs drawn to explore what their hormone levels are during perimenopause. And truly, that's not very helpful in terms of perimenopause management. It's more symptom based. But thyroid is different. Thyroid levels are directly associated with thyroid disease and symptoms. And so having your thyroid levels checked is very important, and that can help differentiate, am I having a thyroid dysfunction situation or am I having perimenopause symptoms?
Great. We did have a question come through. I answered it super briefly about privacy. As you're signing up for the app, you do have the option to look through our privacy policy. We are not sharing with any government entities. I know that can be a very big concern currently. Anything else you would add to that, Elaine? I just want to make sure people know that they're safe. Um,
Yeah. And the coaches don't have access to what you log in the app. It's all about what you share with us directly. We do have access to what you put in your health assessment, what you like the questions that you answer. But in terms of tracking cycles, logging symptoms, we don't have access to that. That's personal.
Great
Thank you so
addition.
much, Elaine and Tracy. I appreciate this was a wonderful presentation. Wonderful, wonderful, wonderful. As you were talking, I was just thinking about one thing I've learned about menopause is, often women who are not in menopause or pre or peri or in their 20s, 30s, they think this information is not valuable. But what I found in my own experience is how you take care of your body in your 20s shows up in menopause. Estrogen is a great buffer. It
Yes.
protects your body from all those things, and you don't feel it until estrogen declines. So this helps. And I think you mentioned it, Elaine, all of the chronic health conditions that surface. This is important information because the lifestyle practices can be incorporated, should be incorporated in your 20s and 30s. Um,
Yes. Yes. And for bone density in childhood, we should get our kids outside playing hard, running around, building those bones.
absolutely, absolutely. Thank you so much.